You're on mute, Therese. Oh, you don't look to be on mute.
Can you hear me now?
Yeah.
Okay, sorry about that. Not a great start. Okay, so my name is Therese Lloyd, and I'm a senior analytics manager in the improvement analytics unit at the Health Foundation. I'll start off by telling you a little bit about the Health Foundation and the team.
Sorry, Therese, we can't see your slides though.
Okay, sorry. Okay, let me.
I can't see your slides.
Okay, let me see here. Okay, now, so I know I can't actually see. Let me just say display settings. So, okay, I'm going to end slideshow. Okay, now, can you see my slides now? Can you see my slides now? Okay, sorry. Sorry, you would think that I'd never done this before. Okay, can you hear me and can you see my slides?
Yeah, it's all great.
Okay, apologies for that. I will start off by telling you a bit about the Health Foundation and the team in which I work. Then I'll talk about my career path and my colleagues' backgrounds. And then I'll talk a bit about sort of the milestones, challenges, rewards, and highlights. So the Health Foundation is an independent charity committed to bringing about better health and healthcare for people in the UK. We're about 210 people strong, and we work within various different directorates. We both do analyses, both on sort of data analytics and economics and policy analyses, but we also give out grants and commission research. We have a rather large endowment, which allows us to be quite independent and not have to seek money for the work that we do. And I'm within the Data Analytics Directorate, which has as aim to ensure that everyone's health and care benefits from analytics and data-driven technology. We do a lot of analyses, looking at sort of the state of play. So, for example, on multiple long-term conditions, clinically extremely vulnerable patients during COVID, care home residents, etc. And then we also do evaluations of healthcare changes, which is the bit that I work in. But we also act as an independent trusted voice on national policy that has to do with analytics. We actively champion analytics across the sector, and we also offer funding and support for innovative work. So the Improvement Analytics Unit, that's my team. We are a partnership between the Health Foundation and NHS England and Improvement. And we evaluate local healthcare changes that as part of national programs to see if they improve care. And we do this by using robust quantitative methods that mostly focus around comparing against a carefully selected counterfactual group. And we do this using routine administrative data. And then we feed back to the local teams and also to national policy makers to both improve care and inform policy. And we're also looking to drive demand for better evaluation within the NHS. So my career path, I have a master's in statistics. It took me a while before I found my statistics, same as everybody else, but I did end up having a master's in statistics, and I started working in the pharmaceutical industry as a statistician. When I was planning on starting a family, all those pharmaceutical companies I was working for were way outside of London, and I had very long commutes. And so when I was looking to start a family, I decided that actually I probably needed to find something a bit closer to home, and Glaxo had an opening for a statistical programmer. So I did that for a few years. But then after I had my second child, I felt like I was doing two jobs badly anyway. So I took a bit of a longer break until he was 2.5. And then just as I was about to start, well, as I had started looking again for work, a friend of mine had an idea for a company and asked me if I wanted to co-found it with him. And it was just too good a an opportunity to pass on. So I did that for about 5 years. I had the very rather grand title of head of research, which I only had one person working for me at the time, so I'm not sure that quite reflected what was going on. But I was also in charge of accounting, HR, everything from paying salaries to writing our policy documents to in-house training. But I realized that actually I was happiest when I was coding macros in Excel to calculate the unit costs of our products, and that actually I wasn't really a salesperson. And so I wanted to get back into statistics, but by then I'd actually not been working as a statistician for quite a while. So I was in the very fortunate position of being able to contact a charity, Prostate Cancer UK, and ask them if they were interested in me working part-time for a short amount of time for free. And that turned out to be absolutely brilliant, because I started off with just helping on little bits and pieces, but then I quite quickly identified sort of an evidence gap that I thought I'd probably be able to fill, that was around sort of calculating the lifetime risk of being diagnosed or dying with prostate cancer by ethnic groups, and the data was readily available. So that's what I did. That culminated in an academic paper, and also became one of their key messaging, and resulted in a national media campaign. So that was great. And off the back of that, I got a job as a data analyst or statistician within the Health Foundation in the data analytics. And that was 7.5 years ago, and I haven't looked back. So I had a very patchy path. So I thought maybe my background might be a bit unusual. So I did check in with sort of various colleagues to see what their backgrounds were. And as you can see from this slide, it's very diverse. I'd say that the most common degree is in maths and then statistics. The most common background is in academia, but as you can see, that could be in microbiology, social epidemiology, biological science, infectious diseases. But we also have a couple of colleagues who were actuaries, one who was a retail analyst, one who was a management consultant. So one of the questions that was posed for us for this talk was whether and when to specialize in either a clinical or methodological area. Certainly to be able to work in the data analytics directorate at the Health Foundation, no particular career path or background is required, as long as, of course, you have a strong quantitative background. And I think there's genuinely diversity is really valued, and so actually having a clinical or methodological expert area could actually turn out to be a good thing if you were applying, but that depends on if there's anybody else who has that background as well. But it certainly isn't a requisite. I think that working in our team, you do end up being a generalist, and then drawing in expertise from specialists as and when required, whether that's methodological or policy area, clinical area. So my advice would be go with what you enjoy doing. If you enjoy doing it, then you'll do well at it. And hopefully that will take you in the right direction. So within the IAU, we have a range of different levels. So data analyst through to senior analytical manager and then head of the IAU. You start off needing mostly quantitative skills. So as a data analyst, you will be working on analyses with support. Then as you become a senior data analyst, you will be more sort of project managing and I think I want to say something else. Let me just look at my notes. Yeah, then you start sort of working more independently, of course, and then also synthesizing the evidence and writing that up. As a principal data analyst, he'll be responsible for a program of work and responsible for the quality and the study design and writing the statistical analysis plan and signing off on the analysis. And then a senior analytical manager, then you become even more sort of just overarching. So you take more of a leadership role, less of the, I mean, already as a principal data analyst, I probably wasn't doing much of the analysis myself, but you critically review others' analyses, you sign off on the analyses, you think about the pipeline of work, and engaging with senior stakeholders. So challenges, I think, speaking to colleagues of mine, especially who came from academia, one of the things that can be a bit of a challenge is how varied the work is and how agile you have to be and to become an expert quickly in different, both topic areas, so policy areas. So we've worked on, for example, multidisciplinary teams, large integrated care programs, care homes, continuity of care in primary care, digital first in primary care. We also use quite a wide range of methods, and we're always looking to expand that. So different ways, matching methods, entropy balancing, regression discontinuity design, synthetic controls, generalized synthetic controls, and then data sets. We've got access to both synonymized primary care data and secondary hospital data, and various other private providers as well. And then the other thing is we have a broad set of audiences, and they require different outputs. So we both write academic papers, but we also write blogs, so short, snappy policy pieces. We also write policy briefings, which synthesize evidence across a program of work and wider evidence. We present also at things, conferences such as Health Economics Study Group and HSR UK, but then also to senior policymakers and to communities of practice within the NHS, etc. I say that's a challenge, but it's also actually what makes the work so enjoyable, I think. Another challenge, especially having come from the pharmaceutical side, is using observational data. So the data quality is not of the same level as clinical trial data, in my experience, and also using observational data has a whole range of issues with identifying a reliable comparison group, and unobserved confounding is always a big issue. But then rewards and highlights. I really enjoy the fact that we do the analyses, but then we are also able to make those links to policymakers. And some of our analyses have directly informed policy for the benefit of patients. So for example, we did some evaluations of enhanced support in care homes, which helped inform the national rollout of enhanced health in care homes, EHCH. Also analyses on multiple long-term conditions informed the NHS long-term plan, and were included in the Department of Health and Social Care's 2021 white paper on health and social care. And our work on ethnic inequalities and survival has been shared with public health teams to help workshop their local initiatives to tackle inequalities. And then the last thing I wanted to mention is what's also really nice is when you do a piece of work that then sort of lives on. So we, probably about 5 years ago, we developed a care home resident flag. So that was using patient registration data that contains addresses. We were able to sort of extract pseudonymized versions of those unique addresses and match those to the addresses of care homes, and thereby identify care home residents in observational data, which had never been done before. It used to be that people just used the postcode of care homes, which is not as reliable. And thanks to that, that was used in the first wave of COVID to really quite quickly analyze residents' hospital use, and also for modeling factors that affected the spread in care homes during the first COVID wave. And that that went to Sage and informed the COVID, what's it called, the way of handling COVID in care homes. So for example, doing regular testing of staff in care homes. And that was it from me. Thank you.
Great, thank you very much.